So Yair is our next speaker, Yair Daon, sorry, from Faculty of Medicine about pooling strategies.
So my talk is going to focus around optimal pooling methods for detection of SARS-CoV-2. This is joint work with Amit Rupert and Uri Obolsky, who is my postdoc advisor. Let me say first what is actually pooling. So I'm not going better. So I'm not going to delve into the whole mechanics of testing for SARS-CoV-2 or any other thing. But I'll just say that pooling is, as you probably know, the act of mixing and testing samples together. There's I'm not sure how it's called in English, swab pooling or tube pooling, where you mix various kinds of samples. The basic method of pooling is I have 10 incoming patients. I pool the test together. If the test is negative, everybody can go home. You're all okay. If the test is positive, then I'm going to sample and test each one of you individually. And this is known as Dorfman pooling since 1940s. Pooling is extremely useful and almost necessary in large-scale testing efforts, such as for SARS-CoV-2, as we have seen. And the main reason is that pooling increases throughput, so I can test more people with less tests. However, pooling also comes with a caveat, reduced sensitivity, or if you would rather, increased false negative rate, or increased type 2 error. And there are two reasons. One is that when you use pooling, you do dilutions. You test less of the biological material. And even beyond that, in the example that I just gave of Dorfman pooling, in order to be positive, I need to be tested positive twice, as opposed to individual testing in which I need to be positive only once. And obviously more can go wrong if I conduct two tests as opposed to one per person. And so the question now I'm going to ask is, can we simultaneously increase throughput and the sensitivity? Or can we eat the cake and still have it? And Obama knows the answer. We can. And so with Uri and Amit, we developed a novel pooling method that has several improvements over common pooling methods. First, our pooling method is built for imperfect tests. So we explicitly take into account probabilities of error, which might not happen in the simple example I just gave of Dorfman pooling. Moreover, we incorporate, or we give the possibility of incorporating risk factors. So for example, if I want to test the entire school, or let's say this entire conference, and I know that if somebody in this room is tested positive for SARS-CoV-2, then the likelihood of another person testing positive for SARS-CoV-2 is greatly increased. And so this is a population structure or a risk factor that we can incorporate. Moreover, as promised, we reduce the required number of tests, and we also increase the sensitivity. And we call this method DOPE, which is initials of the optimal pooling experimental design. We rely on a relatively classic criterion for experimental design called the Optimality. And let me explain how this works. So we have a population. We have some kind of a risk structure. We believe on the population, prior, so-called. And we perform pool tests that maximize mutual information. What's mutual information? It's a mathematical construct, but basically it tells you how much information the data you collect gives you on the population you're interested in, or rather on the population state you're interested in. After we do that, we calculate posterior infection probabilities via Bayes theorem, which I'm not going to go over, and hope you might remember it. And we just repeat until certainty is achieved. And this goes in a cycle. So we have prior risk factors, belief on the population. We find best tools, we test, we collect data, we repeat, we update the prior. And when do we stop? As I mentioned, we stop when certainty is achieved. And this gives us the ability to tune the method's sensitivity. So if we want more sensitivity, we stop after more tests. If we are fine with less sensitivity, we stop after less tests. And as I promised, we can eat the cake and still have it. In this graph, you see, say, various cutoffs or stopping criteria we use for dope in the color bar. And we can see that for this population of size 256 people, with some assumptions on the test behavior. For example, we can get a sensitivity of less than 10% and much less than the competing methods in almost half the number of tests. So this, this was published in the Journal of American Medical Informatics Association. And that's it. I would like to thank the Center for Combating Pandemics for giving me money to do this. Questions?
Yes, do we have questions?
Okay.
So I know there are pooling strategies that are already implemented today in many medical centers. Have you compared against them?
Yes. So the one that's running next to Ben Gurion, they're using basic Dorfman pooling. The manager or the guy in charge told me, I don't want to deal with this. I would just rather do this basic thing. In Soroka, they're implementing, in my opinion, a very cool pooling method based on compressed sensing. However, it comes with the caveat of requiring very low prevalence. So in our experiments, I took high prevalence. Like in the news, when I was doing this, the prevalence of disease among tested people was 7 to 8%. And the method they're using in Soroka, they assume, at least from the paper, they assume prevalence lower than like 1%. So I'm not sure what they're actually doing.
Yeah, I was thinking of the Soroka. Cool. Okay, thank you.